This adrenal gland lecture is a long one, and it's a long one because the diagnostic workup for each of these diseases is quite lengthy, and you have to know every step along the way to get the answer right. So what I want you to do is pay particular attention to the buzzwords of patient presentation and then spend a lot of time learning how to work up each of these diseases. Let's start off with a little bit of physiology before we move into the different adrenal gland disorders. And what we should be paying attention to is what happens when there's too much or too little of a given hormone. All right, so the adrenal gland is a little fat hat that sits on top of the kidney. And that's important because it's going to help you remember the advanced organizer of the physiology of the adrenal gland. The thing in the middle is the medulla, and that is responsible for catecholamine production. Remember, it sits on top of the kidney, and the kidney has a glomerular filtration rate, GFR, to help you remember the zones of the adrenal gland. Glomerulosa, back in, fasciculata, and reticularis. GFR. Now, if you remember GFR for the layers, you can then also remember what they do by the phrase, it gets better as you go deeper. A little fat head on the kidney, GFR, it gets better as you go deeper. It gets better as you go deeper. Salt, sugar, sex. Linking up to aldosterone, cortisol, and then testosterone. Now, we're not going to worry about the sex part, but we are going to talk a lot about salt and sugar, and then we'll finish up with catecholamines. So let's tackle these diseases one at a time, and we're going to start off with Cushing's. So cortisol excess causes Cushing's syndrome. And Cushing's syndrome can be caused by one of four things. One set is ACTH driven, the other is cortisol driven. You could have a lung tumor that secretes ACTH. Or you could have Cushing's disease where there's a tumor on the anterior pituitary that secretes ACTH. Now, the lung tumor that's going to do that is small cell. Or you could have someone who is ingesting steroids. We do this all the time, right, to treat autoimmune diseases. They just may be taking too much. Or you have a primary tumor of the adrenal gland producing cortisol. This will be important in the diagnostic workup because those that are ACTH driven will have an elevated ACTH. Those that are not ACTH driven will have excess cortisol suppressing ACTH. So the Cushing syndrome is caused by cortisol excess. It is one of four conditions, some ACTH dependent, some ACTH independent. Regardless, the patient is the same. Cortisol is responsible for blood pressure and some sugar stuff. So it's not going to be surprising that you find hypertension and diabetes. And these patients will also be obese. Well, that's metabolic syndrome, right? Everybody in our healthcare system has hypertension, diabetes, and obesity. So that's not going to really tip you off. What you should look for is really bad acne, called the moon facies, truncal obesity with a buffalo hump, and stretch marks that form purple striae on the abdomen. And this is probably going to be presented on the test as a picture of someone who has a really big belly with stretch marks, or someone who's got a picture of the back of their neck where there's a hump. And then you have to know how to work this up. So someone comes in with the signs and symptoms of Cushing's. You want to be really sure that this person has biochemical evidence of Cushing syndrome before you start this workup. So there's a couple of tests you can do. What I want you to remember is low, then high. Low, then high. It will help you with the diagnostic workup. So I'm going to teach you low, then high, then give you some caveats. The first test that you would do to say, does this person have Cushing's, is a low dose dexamethasone suppression test. You measure cortisol, you give some dexamethasone. Dexamethasone should suppress the cortisol, but of course it is going to fail to suppress. If it did suppress, it's not Cushing's, the diagnosis is done. A failure to suppress, with a confirmatory test that we'll talk about, gives you Cushing's syndrome. Cushing's disease is the anterior pituitary. We'll get there. Now, since you've already ruled out medications by looking at their med list, you know now that if you get an ACTH, then if you get an ACTH and the ACTH is normal, since you've already excluded the medications, you have your answer. That's going to be an adrenal tumor. Primary hypercortisolism. You identify it with a CT or an MRI of the abdomen and cut it out. But if you get an ACTH and it's elevated, now you know that it's ACTH dependent, but you're not sure which one. So you get the high dose dexamethasone suppression. Low, then high. Because even if you have a tumor of the pituitary, a super high dose of steroids will still cause it to suppress a little bit. Even though it's cancer, it does what it wants. If it's pituitary, there will be some suppression. So if it suppresses, you have Cushing's disease, which is a pituitary tumor, and you need to resect it. If, on the other hand, it fails to suppress, now you're left with an ectopic tumor. Then you have to go find it. This is very rare. That's going to basically be a pan scan. CT of the chest, abdomen, pelvis, hoping you find something. So I want you to remember low dose, ACTH, high dose. Low then high. But also for the test, you have to be really sure that you have Cushing syndrome. So if you get the low dose dexamethasone suppression test, you must also get something else. Either a 24-hour urine, cortisol, or a late night salivary cortisol. Two of the tests are required to say Cushing syndrome. Right. Cushing syndrome, potential causes, what it looks like, low, then high. Don't forget the extra test to confirm biochemically. Let's talk about now what happens when you have too little cortisol, and that is Addison's disease. Similar system. The brain, anterior pituitary makes ACTH. ACTH tells a little fat hat to make cortisol. As you begin dealing with cortisol deficiency, the question you're going to answer is it a problem with the adrenal gland or is it a problem with the pituitary? The reason being that the treatment is going to differ because with the pituitary problem, the renin-angiotensin system is intact. With the pituitary problem, you still have an adrenal gland. If instead you have a deficiency of the adrenal gland itself, you will also lose aldosterone. Okay, so the pathology of Addison's disease is going to be a couple of things. Addison's disease is primary deficiency, destruction of the adrenal gland. That's going to be caused by autoimmune disease, most common in the US, or by TB, most common worldwide. But you could also have a similar syndrome with dysfunctional anterior pituitary. Know that that exists. We're going to be talking about Addison's disease, the actual thing, the problem of the adrenal gland. So there's going to be two potential presentations, the acute and the chronic. In the acute case, you lose both cortisol and aldosterone. Cortisol is required for your blood vessels to work. Aldosterone is required to reabsorb sodium so you hold on to fluid. Thus, no volume and no tone. These people are hypotensive, nausea, vomiting, coma. They are deathly ill at death's doorstep. A more chronic process also exists. So in acute, it's generally going to be hemorrhage, and then chronic is going to be more the infiltrative diseases, autoimmune, or metastatic malignancy. In the chronic cases, you're still going to be hypotensive, but it's going to be more orthostatic than frank hypotension. And because cortisol is not being made, there's no feedback to ACTH, so ACTH is being made. A byproduct of ACTH being made is hyperpigmentation. And because aldosterone is not being made, you lose the ability to hold on to sodium and kick out potassium. So while not common, low sodium and high K might tip you off to Addison's. So the question becomes, A, do they have Addison's disease? And B, is it a product of the pituitary or of the adrenal gland? The diagnostic workup, you're going to find somebody you think has Addison's. The first step to ask is, do they have sufficient cortisol? Getting a random is the wrong thing to do. People do it all the time on the wards. Not a random. You want an early AM cortisol. Because if the cortisol in the early morning is normal, you've ruled out the disease. But of course, for our discussion, we're going to have a low cortisol. So now you're thinking it's Addison's, you're getting excited. The confirmatory test is going to ask, is there a deficient pituitary or is it a deficient adrenal gland? And you do that with a cosentropin stim test. You give the patient ACTH. And work with me. If you had an intact adrenal gland, just lacked ACTH, and you gave ACTH, the adrenal gland would respond. But if you had no adrenal gland, it wouldn't matter if you gave them more ACTH, it wouldn't be able to act on anything. So, with a cosentropin stim test, if the cortisol rises, the problem was with the anterior pituitary, and now you're into that pan-hypopit MRI. What you expect in Addison's disease is the cortisol will not change. And now you've got a problem with the adrenal gland. You do want to image the adrenal gland, so you'd get a CT or an MRI. And you don't have to worry about interpreting the CT or the MRI, just know that you should get it. And the reason why this is important is because if it is a problem with the anterior pituitary, the adrenal gland is still intact. All you need to do is replace cortisol. But if the adrenal gland is lost, you've lost both cortisol and aldosterone, you'll need to replace both. To replace both, you have to give cortisol and fludrocortisone. All right, so this is the first section. What happens when there's too much cortisol and not enough cortisol? Too much is Cushing's. Look at the hypertension, moon phase, truncal obesity, buffalo hump, low then high. trying to figure out what the cause was. And Addison's disease presents either as acute devastating hypotension, nausea, vomiting, coma, or a slowly progressive hyperpigmentation and orthostatics. The workup there is going to be cortisol, then concentropin stim test to separate the anterior pituitary from the adrenal gland and treating accordingly. Let's move on and talk about some of the other diseases of the adrenal gland. And since we just finished talking about aldosterone, let's talk about what happens when there's too much aldosterone. That is going to be Conn's syndrome. The renin-angiotensin-aldosterone axis is independent of the HPA axis. We learned that in Addison's disease. In the renin-angiotensin-aldosterone axis, the JG apparatus in the thick ascending limb secretes renin. And renin then turns on Ang2. And Ang2 tells the adrenal gland to make aldosterone. Aldosterone inserts these channels into the collecting duct to reabsorb sodium and expel potassium. And it does so aquaporins can be inserted under the guise of ADH to reabsorb water. This is what happens when there's low flow through the kidney system. This is intentional, an attempt to hold on to fluid to increase the GFR. But there might be a tumor that, independent of this system, secretes aldosterone. So unlike cortisol, where we focused a lot on the HPA axis, this needs to be focused all on a new endocrine axis. So the pathology of Conn's syndrome is either going to be a primary tumor, which is Conn's, or it's going to be a product of renovascular hypertension. That is fibromuscular dysplasia, which is the young woman, or atherosclerotic disease in the old man. And the patient is going to present with hypertension and hypokalemia. While that makes sense, an increase in aldosterone is going to cause an increase of sodium reabsorption and loss of potassium, so the hypo-K, and reabsorption of all that water is going to lead to an expansion of the fluid volume. Most of the time, they don't present with that. On the test, they will. In life, they won't. What you should look for is secondary hypertension. That is refractory hypertension to even 3 or more medications. All right, so your goal is to decide, is this a problem of aldosterone? And is it a tumor or is it a problem of the renal artery? So you see somebody who's got the signs and symptoms of Conn's, and you want to work it up. The first thing you're going to do is an aldo to renin ratio. Because if aldo is not elevated and renin is not elevated, you have a mimicker. Don't commit too much of this to memory, but your differential includes congenital adrenal hyperplasia and licorice ingestion. If aldo is elevated, and so is renin, that means that renin is driving that aldosterone elevation. The aldo to renin ratio is less than 10, then you have renovascular hypertension. And in the case of fibromuscular dysplasia, you will stent. In the case of atherosclerotic disease, you won't stent. You'll just deal with the blood pressure. Well, the fun stuff is if the aldo is elevated, renin is not, which means you have autonomous secretion of aldo, and the aldo to renin ratio is greater than 30. Now you've got Conn's. The confirmatory test is a salt suppression. where you give a salt load, and what should happen is aldosterone should decrease, but it doesn't. Failure to suppress prompts you to get an MRI, because now you want to find it, because what you want to do is cut it out. And so what's going to happen is you might see a tumor, or you don't. Regardless, you need to get the adrenal vein sampling. Because even though there's a mass on the imaging, in 50% of the cases, the side without the mass is hyperfunctioning. So don't forget the adrenal vein sampling before you go to resection. All right, cortisol's done, aldosterone's done. They're not going to have any issues with testosterone. Let's talk about pheo. Pheochromocytoma. The pathology is a catecholamine secreting tumor. This would be of the medulla. And the patient is going to present with the P's. It'll be paroxysmal pain, that is headache, pressure, hypertension, palpitations, that's tachycardia, and perspiration. The diagnostic steps here are very simple. You have two things to choose from. You could get a plasma-free catecholamines, or you could get a 24-hour urine, metanephrines, or VMA. Which one do you pick? It's really tough to decide between them. But what's said is, if you really think that it's pheo and they're in a crisis now, draw the blood. If you don't know, or you're trying to work up an incidentaloma, get the one that's more sensitive, that's a 24-hour urine. Either one of these, I think, would be correct. Back in. Once you've confirmed the diagnosis, you want to find the mass with the CT or the MRI of the abdomen. Don't forget the adrenal vein sampling. And where they usually ask questions is about the pre-operative management. This is all theoretical, but everyone still does it because no one's willing to take the risk. Pheochromocytoma is a catecholamine. If you poke it, it can release a lot of catecholamines and they can go into a hypertensive crisis. So you want to give them an alpha blockade first. That prevents the hypertension. Then beta blockade, because you don't want them to be unopposed alpha. Then resect. All right, so a lot of tumors we talked about. The last thing we can close with is the easiest, and that's what you do when you see a mass on the adrenal gland. That is, how do you handle an incidentaloma? An incidentaloma is nothing. But you got a scan for something else, right? A CT or an MRI of the abdomen, and all of a sudden you have this thing. Now you have to ask, is it a thing or not? And the way you do that is by ruling out everything else. So you have to rule out cons, rule out Cushing's, and rule out pheo. And you do that with a 24-hour urine. Checking for, no, you have a 24-hour urine. And then you treat it. Either it will be less than 4 centimeters, in which case you watch and wait, or you resect it if it's greater than 4 centimeters, because it might be cancer, or if it's functioning. And you just answer the question, is it functioning, by getting a 24-hour urine. I know this was a long one, but there's a lot in here you have to know. It's pretty easy, but there's just a lot of details. So to review the back half here, we looked at Conn syndrome, trying to decide, is it appropriate renovascular hypertension, or is it a tumor? The way you do that is with the aldo to renin ratio after identifying hypertension and hypokalemia. Do stent fibromuscular dysplasia, don't stent atherosclerosis. And before you resect the tumor, make sure you confirm laterality with adrenal vein sampling. Pheo, paroxysms of pain, palpitations, pressure, and perspiration. Get the urine studies, alpha blockade before beta blockade, before resection. And then incidentaloma. Use everything else you've learned in this lecture. Rule out hyperfunctioning adrenal gland with a 24-hour urine. Leave it in, serial imaging, or cut it out if it's big or hyperfunctioning. That is the adrenal gland.